though, right?
Yeah,
Yes.
can you hear me?
Yes. Good afternoon, Chairman.
Good.
All right, we've started.
Okay, good afternoon, everyone. We're thrilled to be presenting a timely panel entitled Issues Affecting Native American Communities During the COVID-19 Crisis, sponsored by the ABA section of Civil Rights and Social Justice. This panel is one of many in a series of rapid response webinars on the COVID-19 pandemic. We are actively planning additional COVID-19 programming on a variety of issues. So there will be an evaluation at the end of this if there's other topics you would like to have as webinars. Before we go into our program and how it will work today, I'd like to introduce Judy Perry-Martinez, President of the American Bar Association, for some introductory remarks. President Martinez.
Thank you, Mary, and thanks for your leadership, and all of those in the panel. Thank you so very much for your contributions that I know you'll make today. We are delighted to have this webinar going on today in that series that Mary talked about, which is so critical during this pandemic that our entire nation is facing. In order to serve our association's members and the general public and provide timely resources, the ABA has set out on making sure that sections such as the section of civil rights and social justice are really taking the lead in sending out information across the country that we know will be impactful and valuable to those lawyers who are serving and also to those whom they serve. We're grateful for each of you who have gathered on this webinar call today for the fact that you are here and showing your concern about these issues and what we know is a lifetime and career of service to the Native American community and urban communities and so many others who have needs that are just escalating as we face this crisis. Today's program focuses on how Native Americans are being impacted through this crisis, both from a health and an economic perspective. This topic is particularly important as COVID-19 has the capacity to severely impact Native American communities due to the health disparities that Native Americans experience in terms of diabetes and heart disease and so much more, as well as the substantial economic challenges and healthcare inequalities that many tribal communities have been faced with even before this crisis started. The ABA has long supported Native Americans and tribal governments. For instance, the ABA has passed supporting policies that support long-term and stable funding for tribal justice systems and also the Indian Health Service. At our annual meeting this past year in August, we urged stable funding and advanced appropriations for the Indian Health Service. And we know that one of the many implications of the stay-at-home orders is that there may be likely an exceedingly large increase, as there was in my home state of Louisiana after Katrina and after the oil spill, in domestic violence. The ABA has supported the tribal VAWA positions, and just early this year, we supported legislation and resources, significant resources that we think are needed to combat the epidemic of missing and murdered Indigenous women. During this crisis, the ABA is working hard on several fronts to effectuate these policies through webinars like this one and others, and other methods of sharing our policy positions and lessons learned by attorneys across the country. We are glad that you're able to join us today for a discussion from these experts about these issues and this important, critical topic to our entire nation. And we ask you to consider thinking about joining us in the ABA. With that, I'll turn this back over to our moderator, Mary Smith, the Secretary of the American Bar Association, and ask that she begin this program. I know you look forward to it, and I know you'll get much out of it. Thank you all, and know that the American Bar Association is here with you.
Well, thanks so much, President Martinez. And as I didn't really introduce myself, I'm Mary Smith. I'm Secretary of the American Bar Association, and I previously was head of the Indian Health Service. So during today's program, we encourage you to ask questions of our panelists. We're going to save time at the end for questions, and not to worry. Even if your question does not get answered during the program, you can follow up with the speakers or through our evaluation tool. We will try to answer as many questions as we can. As an attendee, you should see a control panel with controls such as audio options, chat, raise hand, and Q&A. For the purposes of this webinar, we ask that you submit your questions through the Q&A, not the chat function. If you do not see these controls, please ensure your screen is not idle. We will address questions at the end of the panel. We're going to try to leave about 15 or 20 minutes. We will be sharing a recording of this program for everyone who has registered so that you can share it widely with your networks. Please feel free to leave us feedback or ask questions to follow up. And with that, we're thrilled to bring you today's program entitled Issues Affecting Native American Communities During the COVID-19 Crisis. And I have to just, a point of personal privilege, we have a superstar panel. We have the top experts across the entire country on this panel. So today, our panelists are Kevin Ellis, the Chief Executive Officer of the National Congress of American Indians, Stacy Boland, Executive Director, National Indian Health Board, Elizabeth Coronado, Staff Attorney, Health and Human Services, Lummi Indian Business Council, Dr. Charles Grimm, Secretary of Health, Chickasaw Nation Department of Health and former Director of the Indian Health Service, Virginia Heideck, Executive Director, California Consortium for Urban Indian Health, Geraldine LeBeau Church, Chief Executive Officer of the Great Plains Tribal Chairman's Health Board, Doreen McPaul, Attorney General, Navajo Nation, Department of Justice, Naomi Miguel, Professional Staff, House Committee on Natural Resources, Subcommittee for Indigenous Peoples of the United States, and President Brian Newland, Bay Mills Indian Community of Michigan. And I have a surprise. We have a surprise honored guest today. We have Chairman Grabhalva from the House Natural Resources Committee who's going to start us off. So Mr. Chairman, with further ado, we look forward to your remarks.
Thank you very much. The Bar Association, to you, Madam Secretary and Madam President, thank you very much. And just a quick update. And I think you know, the jurisdiction that the Resources Committee has the privilege of, its jurisdiction for it to be, you know, dealing with issues of Indigenous people across this country and on tribal lands. So we take that responsibility very, very seriously, and a trust responsibility that is enshrined, and a trust responsibility that we're pursuing aggressively, and it's translating into this that we during the development of the packages and the last CARES relief package, with the support, the advice, and the expertise of Indian country, we pushed for a robust amount of resources to address what was going to happen as a consequence of the pandemic in Indian country. And we based it on history. We based it on a history of neglect, and that we based it on the fact that it was always where you go through the recession that happened in 2008 and other instances in this country where the support for Indian country not only was not present, but when it did appear, it lagged behind and took so long to address what were very, very critical needs in Indian country. And we didn't want to deal with benign neglect or outright neglect in this instance, and pushed it forward. And the second package, the call I just got off of, again, asking for increased funding as the consequences of the economic cost related to saving lives, and there is a cost attendant to that, Indian country is going to be hit hard economically, and so relief packages need to be put together now to sustain employment, but more importantly, economic development and other efforts that are going on need to be protected and need to be made whole. On the health front, which is of a critical concern to all the tribes that we've spoken to, we continue to push on that issue, but I think it's also the issue of oversight. The committee's taking the issue of oversight very, very seriously. We're going to have a hearing and to get an update next week where the subcommittee on Indigenous people of the U.S. are going to hold that hearing. I'll be joining it. All other members will be joining it to get an update, because I really believe that we need to keep on not only on top of this, but also assessing it step by step. The oversight is important because, initially the fight was over getting any funding. The majority of the Senate didn't recommend any. The administration didn't recommend any, didn't want any set-asides of any kind. That didn't happen, and that was a major victory for Indian country and for those of us that felt that that was vital to having that package. So going forward, knowing that our oversight function is going to have to be critical, we're going to rely on people that are on this call, other leadership in Indian country, people on the panel, to help guide us to make sure that we are holding the administration's feet to the fire in terms of what needs to be, how it gets there, and the kinds of resources to back it up. And the same philosophy going forward in terms of the economic relief response. I say all that as the committee realizing, and those of you in the field realize that when you talk about social justice and equality in this country, we're also focusing on frontline communities, environmental justice communities, to get an update as to the indications either from New York and Chicago are that the people most impacted, and I think that applies to Indian country in terms of testing positive and when the tests do get there, and the fatalities are happening in communities of color in an Indian country. And we want to highlight the fact that this response to the pandemic, let us take this as a point that we have to have parity and equity in how we treat people and how we get support to them and how we deal with this crisis. This is no time for collateral damage. This is no time to repeat the mistakes of the past. And so that forum as well, and that oversight hearing as well, is going to be very important to highlight the fact that there are communities based on socioeconomic reasons, based on racial issues, and based on historic issues that are not receiving the support and are suffering disproportionate and disparate negative effects from the pandemic and from the disparate approach when it comes to receive the full breadth of what they need in terms of health intervention and economic intervention going forward. That's what our committee is doing, and continuing to advocate for the things that we've been advocating for Indian country with the support of Indian country. And going forward, this pandemic, if it's taught anything to the American people, that there is a role for government in response to a crisis, that it's not just about limiting government's role, it's about expanding it with resources. And the other thing that we've learned is that we're all in this boat together, and nobody should be left aside, left on the shore, or not dealt with as we go forward. This is a health crisis nobody's making, but a health crisis that we have been slow to respond to. And I don't want that attitude that, we've dealt with it and leave the consequences for other communities, whether it be Indian country or poor communities or communities of color, to have to deal with the consequences of lack of attention and lack of resources. So that's my limited presentation. Thank you so much, and look forward to continuing the work. Thanks a lot.
Thank you so much, Mr. Chairman, for joining this webinar and for all the work you did fighting to include Native Americans in all three bills, and particularly the last one, the CARE Act. We really appreciate all your work, and I love that you said you're going to continue doing hearings and continue oversight to ensure that Native American communities and Native Americans across the country are not forgotten. So thank you so much, Mr. Chairman.
Thank you.
So this panel, I think we have a lot to cover, so obviously it's going to be at a somewhat high level. We're going to cover three different areas. The first is the legislation that has passed. The second is the health issues concerning Native Americans and tribal and urban Indian communities. And the third will be the economic impact, including impact on tribal justice systems and on prison systems and other issues impacting Indian country, and also a little preview about what we think will be in the next bills and what could help Native Americans and Indian communities. So I'm going to turn first to Naomi Miguel on the House Committee on Natural Resources Subcommittee for Indigenous Peoples to do a short presentation, given her background on obviously working on the legislation that has passed so far. And as the chairman, I know, mentioned, Indians were not included initially, but there was a lot of people, including many of the people on this call, who fought tooth and nail to make sure they were included. So Naomi?
Thanks, Mary. And also thank you for the chairman to join us today. I know he may be listening in a little bit, but he does have other calls to go to, so he may just drop off as needed. But just to give you a quick overview of the presentation, you'll probably have some of the other groups go into deep detail for the bills that were passed. So I'm just going to do a quick congressional overview of some of the bills that we had. Also going to go into what we've been doing for the committee, timeline of what the responses that we had for COVID-19, resources that we've created, and as the chairman mentioned, some of the oversight issues that we're going to start digging into, and potential ideas for a future package moving forward. So just a quick overview. The first bill related to the coronavirus, specifically related to Indian country, was passed on March 6th. And this bill provided $40 million to tribal organizations and tribes and urban Indian health organizations. The second package was Families First, the Coronavirus Response Act, which provided $64 million in appropriations for testing through IHS. And then the third package that was more recently passed, the CARES Act, had a number of appropriations ranging from housing, Indian education, BIA, BIE, Bureau of Indian Education, Bureau of Indian Affairs, federal distribution program for Indians on reservations, assistance for tribal fishermen during this, and they're able to get disaster assistance. And also tribal businesses are eligible for 2 other grant funds through the Small Business Administration. So here's a quick overview of what we've been doing on the committee. This is a timeline of the bills I just mentioned, but also some of the oversight that we began to have in the initial phases of this pandemic. So just to give some background, tribal leaders had already reached out to Chairman Grijalva prior to the passing of the first bill to let him know of their concerns in preparing for this pandemic to potentially reach their lands. So that triggered off a lot of actions on our end to follow up with. On March 13th, the House committees had a call with IHS, go over any type of initial steps they're taking to try to get either outreach, relief, or supplies to tribal organizations and tribes themselves. Similarly, on that same date, Vice Chair Holland and Subcommittee Chair Ruben Gallego introduced the bill. On March 18th, Congressman Grijalva sent a letter to IHS asking for clarity on the coronavirus response to Indian country to IHS, specifically asking about supplies, testing equipment, and availability, acknowledging the fact that some tribal members may need to have quarantine. So what were we going to do in terms of housing? And then on March 20th, Subcommittee Chair Gallego also led a letter to the CDC to inquire about the funding that was provided in that initial bill in March 6th. that also led to CDC releasing funds that were specifically to tribes. On March 14th, the House passed the Families First Coronavirus Response Act. And similarly, a few weeks later, Chairman Grijalva, Vice Chair Deb Holland, and Subcommittee Chair Gallego held a member level call with IHS to discuss their plans leading forward and any potential funding that they needed, or get an idea of what their plans was to really address this pandemic for Indian Country and prepare Indian Country for this pandemic. Following that, Chair Grijalva released a press release kind of giving an overview of what he heard. Some action items that IHS did state on the call, and also went into further inquiry on it, and we'll get to that in the oversight section later on. On March 27th, IHS did release some funding that was related to the March 14th bill. So as you all know, this is a very rapid moving, complex issue, but also an issue that addresses a lot of Native people on the ground. And what we were hearing on the committee was that there was no place for tribes to kind of find resources or so we wanted to create, fill in that gap as a subcommittee in the committee, and Native issues being a priority for the chairman, we created a list of resources for Indian Country and insular areas, but I'm going to focus on Indian Country. Indian Country, we created this website that's a coronavirus in Indian Country. It has a number of resources and information, including some of our press releases and action items that we've been doing, news stories that are updated. We have a fact sheet, and this fact sheet was actually created and based off of IHS's frequently asked questions. We wanted to make sure that we were directing tribal members, but also tribal leaders, to other resources from the federal government, so that it could be a one-stop shop where tribes can kind of find what they need, but also be redirected to agencies that can also further help them. This is an infographic that was actually created or highlighted as some of the statistics that National Indian Health Board had from their survey responses that they conducted. We wanted to highlight that on the committee, mainly to show that even though this is a pandemic that's hitting Americans, across the board, Indian Country also has a lot of health disparities already there, and so the survey that they conducted was really helpful in identifying, the amount of resources that are available to tribes right now. We also have an Indian Country public forum where tribal leaders, tribal members are welcome to fill this out. You can keep them anonymous or not, but that's also available on the website. What we do with that information is actually use that for legislation. So in some of the CARES Act, you'll see in the following slides that I kind of have them up there. Some of the issues that are identified from folks on the ground, what our team tries to do, along with a lot of the national organizations, is to make this clear picture to members of Congress and policymakers on the Hill, to let them know that a lot of these bills and policies that we pass do have on the ground impacts, and actually have a lot of needs that need to be met right now. So I'm sharing with you just a few quotes and sections from the CARES Act that are currently being implemented or going to be implemented. This one in particular that's talking about food security, I believe we had about 30 million or 300 million go to that program. I can let Kevin and Stacy quote me on that. I know they're going to get into detail. And even when it comes to housing. So a lot of these issues that we're seeing happen, our committee is trying to be more mindful of the impacts it's having on the ground. So this is our oversight that the congressman mentioned. I just wanted to flag too that Congress is working remotely right now, which is very unprecedented. And so when we say oversight in hearings, it may not be exactly what you think. I just out of humor put the House floor background on this call just to kind of give you an idea of like I'm pretending I'm at work, but I'm really in my living room right now. So our oversight's going to look a little different. We are sending letters to various agencies. We are also starting to collect a lot of the stories to develop the next bill. We have our website as a resource, but also as the congressman mentioned, we're trying to hold more online type hearings or roundtables to make sure that we're giving Indian country and folks that may not have a voice out there the opportunity to share their stories to Indian country and those that need to hear it. So just kind of touting this forum just one more time. And then we also have a committee newsletter for folks that want to follow us and keep up to date on things that we're doing in the committee. I have that up there. And then that's Sapa is thank you and Thanatham, that's where I'm from. And that's my contact information, and hopefully gave you enough time so other people can speak. But I don't know if we're going to do question and answer right now or.
No, we're going to do them at the end. We'll do it at the end. All right. Thanks so much, Naomi. I'm going to turn to Kevin now to kind of just go over at a high level the provisions that affect Native Americans and Indian country throughout the bills. So, Kevin?
Hello, everybody, and thank you so much, President Martinez, Madam Secretary, Chairman Grijalva, Naomi. Thank you very much for your continued support. It's greatly appreciated. We need champions like you to be right where you are to make sure this stuff gets done for us. But my name is Kevin Ellis. I'm CEO for the National Congress of American Indians. I'm an enrolled member of the Forest County Potawatomi community in Wisconsin, and I'm very proud to be able to be part of a team at NCAI, which is the oldest, largest, and most representative American Indian Alaska Native organization in the country. We, if you're familiar with us, we do so many things. We cover, everything under the sun with respect to issues that are important in Indian country, and in fact, all parts of tribal communities, their governance, their lives, and general welfare. No doubt the last couple months have been a very difficult time for Indian country, very concerning time. When you look at some of the statistics and some of the things that have already been said previously, that the existing health disparities, the overcrowded home situation that's at least 16 times the national average. It's a tinderbox, if you will, for this virus. Should proper steps not be taken by our leaders in Washington, D.C. in safeguarding our community. So we were hyper-focused on this, along with all our partner organizations, in making sure legislation addressed our particular needs. My first couple slides deal with stuff that Naomi already shared, so I won't go over that in the sake of time. The first couple bills were heavily focused on making sure Indian Health Services and CDC and all the infrastructure was in place to begin get funding out to where it needed to be to get out in front of this the best it can. Naomi did a great job talking about those two, and any further specifics I'm going to defer to my good friend and colleague Stacy Boland at NIHB to speak more to that, as that's in their wheelhouse, and there's nobody better to talk about that than anybody else. What I do want to talk about maybe in a little more, and again, just kind of piggyback off what Naomi spoke to and the chairman, the COVID-3 bill was really an important piece of legislation for us. We could see what happened in the activity and what occurred in the first two bills, but we knew that the C3 bill was where we were going to start seeing relief for Indian country. And so it was all hands on deck, both at NCAI and across Indian country, to make sure that we had a measurable footprint in that piece of legislation. And what may have been alluded to initially, the House penned the first two, the third bill was coming from the Senate, and in the initial drafts that we saw in conversations, Indian country was basically left out. There wasn't a whole lot of discussion about Indian country. It seemed that we had been, forgotten once again, and that really raised the alarm with all of us in Washington D.C. and all our tribal leaders, some whom we have on this panel today, in not allowing that to happen. And it was during this time I was, I live in Baltimore and drive into D.C. every day. I was driving up 29 that morning and heard all kinds of, interviews with federal officials and state officials and some of my friends at the National Urban League and NAACP that run and advocate for important interests for other minority groups, talking about their communities and what risk was going on and what existed in urban environments and these other minority communities, but nothing was being said about, Indian country. I heard there was nobody on TV or on the radio, no tribal leaders, no tribal advocates, nobody speaking to this. And it really, it really pinched me and it really hurt. And I reached out to my friend Mark Morial and some of these other folks saying, hey, look, you've got to help us move this agenda, because if we're left behind, it could be a catastrophic situation. And if it starts, it could be too late. So that really got, us mobilized even more emotional than we already are. And NCAI worked with our partner organizations in organizing a collective, unified, collaborative effort to approach the C3 bill. We all had been a part of ARA back in under the Obama administration. And we learned from some of our mistakes there. We were so excited about that everybody was attacking the Hill from all 360 degrees on the compass and kind of confusing our friends up there. And we learned from that we, in order to really get stuff done and have the Chairman Grijalvas of the world and the Senator Udalls of the world, the Senator McSally's and Senator Daines and Chairman Gallego, to have them help us, we needed to have a clear message. So what NCAI did was work with our partner organizations and over 120 lawyer lobbyists that work in and around Washington, D.C. that represent tribal interests. And to create a list of everything that we would want in that bill. And this group did an amazing job. They have identified 42 policy priorities and they sent them to NCAI, and I put my whole team in NCAI's entire policy team tasked on this to then kind of organize that list. And we broke it up into 3 sections, healthcare, nutrition and education, economic development and employment, and then tribal governance and housing. And we categorized those and put all 42 of those policies in one of those 3 buckets, and then floated it out with this big group that we had. And folks volunteered to participate in these work groups. And then what these work groups did over the course of 3 days, because we had no time. I mean, this was moving at the speed of light. They vetted each of those policy priorities. They priced each one of them, and then developed draft bill language that the Hill could use and work with. And that way, we were kind of getting out in front of this and having a better say on directing what the message was. We already knew what our champions knew, and we already knew that they would support it, but we had to kind of help them out a little bit and fine tune it, make it clear, and have Indian country direct that and make sure that our interests were covered. And it resulted in working round the clock, literally. The groups worked around the clock, and we produced 3 letters that went to both sides of the Hill the Friday night before the last weekend when the bill was signed early the following week. And then after that, we assigned everybody took assignments on, okay, now that we had the letters crafted, the ask articulated, the draft language in place, who was going to go to where and speak to who. And everybody stepped up. They worked with what they knew. They contacted where their spheres of influence were. And we really had a really solid working group that did get a lot of success. Okay, we didn't get everything we asked for, but when you look at one point, we weren't even in the bill, to a point where when the bill was signed and came out, we had a little over $10 billion earmarked for Indian country. A lot can be said for when it went into that. And our hats off to our tribal leaders back home that are facing this day to day, because they were feeding content to us. They were feeding content through our organizations. They were feeding content and needs through their representatives. And all that flowed up into the message that the Hill was literally bombarded with over a course of 4 or 5 days and around the clock over the weekend to make sure it got in. And so what did we see? Naomi covered some of this, but at high level, some of the big things, $453 million for the Bureau of Indian Affairs programs. That can go to welfare assistance program, public safety and law enforcement. $8 billion tribal set aside for a coronavirus relief fund. That is an enormous amount of money. We were looking for 20 billion. We are still looking for 20 billion. This is still live and going, and we need at least 20 billion. Okay, and we think it'd be fair. But the 8 billion is a good start. Now, the Treasury and Department of Interior are going through the consultation process on this as we speak. The second one will be tomorrow. There's some work that needs to be done here. Although there's $8 billion here, the language in the bill is less than desirable. It kind of focuses very heavily, well, exclusively on expenditures and doesn't speak to lost revenues. For all of those that work in Indian country and have a familiarity with Indian country, tribal governments, yes, they do get federal funding and program funding through the federal government, but many tribes, a very large portion of the funding that goes for tribal government programs comes from revenues from the tribe's businesses. And because of the safety for the community, because of the safety for their employees, like everywhere else that we see, those businesses are closed. And because Indian country doesn't have a tax base, with property taxes and income tax and all that other kind of stuff, when this spigot turns off, there is no money for these programs. So we really need to work with Treasury. We really need everybody's help to work with Interior and Treasury and getting them to understand that we are governments just like state governments and federal governments in providing important programs and delivering invaluable services to our community members. Our funding stream is a little bit different and enormously packed in a larger way than some of our sister sovereigns. So we need to really work with that. And if it doesn't work out right in this one, we've got to get some fixes, and we need our champions like the chairman to really get Congress to understand that a bill needs to pass that addresses the lost revenues that tribes are facing. We saw another $1 billion earmarked for Indian Health Services. Stacy can talk about that. Housing. Housing's a monumental problem. Naomi spoke to it. I could talk about it endlessly. The housing situation in Indian country, like I mentioned, overcrowded at least 16 times the national average. We have many of our homes, a large percentage of them that have problems with them, whether it be lack of plumbing, other kinds of things. And a lot of that is caused by the long-term underfunding of housing programs that, even though there may have been small increases throughout the year, when you factor in inflation, it's really flatlined. And when you have flatline funding streams over a long period of time, it shouldn't be a surprise to anybody that you have problems. I saw some questions about FDIPR in the question and answer. Yes, there's $100 million for the FDIPR program and making sure that that's solid. We haven't. I don't know. Some of us will go to the grocery stores and we see that there's no paper towels or toilet paper. I can't even find dishwashing pods that go in my dishwasher. Who knew those would be out? But there's going to be a point where it might impact our food supply. Okay, so it's really important that these communities are allowed to have the funding to get out in front of that and know what's in store for them. So I'm gonna just stop at this portion for me to say, for the last week, we've been in, now that the bill has passed, these same groups have been working almost 24/7 to communicate now to the administration that has been tasked with pushing out money to Indian country, how they're supposed to build in their guidance that takes full consideration into the needs of Indian country. So we've put out 9 different letters, and actually another letter went out today in reference to this new bill that may come out this week. We call it COVID 3.5. To 9 letters to the administration to instill upon them the importance for flexibility and respecting the tribal government's need to customize these funding streams in a best way that fits into their program, and that this money is supposed to be helpful and needs to get out there easy and not have these restrictive hurdles and time-consuming things that cause the money to be delayed. So again, thank you everybody for your time and consideration, and I turn it over to the rest of the panel. Thank you.
All right, thank you so much, Kevin. That was really helpful. I'm going to turn to Stacy now to kind of talk about the health provisions in the bills and from her perspective how this all evolved. And then following that, President Newland, I'll turn to you as a tribal leader perspective about how the bills evolved and what your thoughts are. So Stacy?
Thank you. For some reason, I cannot get my mouse to work, so I cannot share my screen. That's a little frustrating, and I don't see that getting fixed anytime soon. So I'm going to go from my heart and my brain. My name is Turtle Woman. I'm Stacy Bolin. I'm a member of the Sault Ste. Marie Tribe of Chippewa Indians from Michigan, and I'm the CEO of the National Indian Health Board, a position I've held for just over 15 years. I am very pleased to be with everybody today, and really privileged to have the opportunity to speak as a representative of all of the tribes in the country for the provision of healthcare and public health for our people. Of course, we find ourselves in a time like none other, not just for Indian country, but for the rest of America. Ironically, when I read papers from back home, Michigan, of course, has a particularly high burden of COVID-19 among all of our people. When Henry Ford Hospital and other mainstream hospitals talk about how traumatized they are that they have to put some kind of rationing of healthcare in place, it is it's reminiscent of everyday life in Indian country, using a priority system for purchase care, trying to find specialists who will help our people, trying to get the right number of physicians and healthcare providers. That's every day in Indian country. And it brings me no pleasure to acknowledge that this is what the rest of America is now experiencing. But when I read the paper, it reads like Indian country today. And that is a sad state for all of us. But I'm very hopeful that mainstream America will take this opportunity to look at what is happening and realize this is unacceptable, not just for them, but for Indians, Alaska Natives, the indigenous people of these lands. The National Indian Health Board launched a COVID-19 Tribal Resource Center. You can find that on our website at www.nihb.org. I do have a slideshow that I don't seem to be able to access, and I will share that. I have shared that with Allie, and everyone who's on this call is welcome to have that, and I hope it's part of the record. So I may speak quickly, but it's backed up by the slides, and you'll see all the content there that you might need. And you can also always contact me or members of our team at NIHB. When NIHB moved into remote work, we retooled our entire organization to be a COVID-19 response team. We brought in April Hale, who's a native. That is
Your
awesome.
slides are up. Yep,
Who did that?
the ABA.
Well, thank you, ABA. This is spectacular. Okay. Are you going to switch them then? I don't have control,
Yes.
right? Okay,
Yeah, Allie
wonderful.
will do it.
Let's move on. Please switch the slides. Okay. This is about the COVID-19 Resource Center. Thank you so much for putting this up there. It makes it a little more dynamic than just describing how dynamic it is. We have, as I said, retooled our entire organization to be a COVID-19 response team for the provision of healthcare in Indian country and for the building and capacity of public health. Tribes all over the country, our people who receive care through the ITU system, they all need information. They need good, solid information. And we are committed to providing that for them. We've also partnered with the Association of American Indian Physicians, and we have a blog that is populated by the writings of our Native doctors on the front lines. And tonight at 5 o'clock, we will have a town hall with a panel of American Indian physicians so that our people can be heard from the ground up. Because this is a time that people are isolated, even more so, I think, in our tribal communities. And this is a way to connect and get some additional help and resources. So next slide, please. We've been very active in working with mainstream media outlets and tribal outlets. Our policy and legislative team has worked tirelessly to reach out to tribes across this country and make sure that we're getting it right, that the things we're asking for and the visions that we have for what will work for the tribes in this crisis are informed and guided by the voices of tribal leaders across this country. We've had at least 10 calls nationally with tribal leaders. They have ranged in attendance from 600 to 1,300 people, trying to ensure that tribal voices are heard and that tribal voices are reflected in the packages that we're sending up before Congress. And we're making use of the mainstream media to ensure that our voices are heard by those who can make change as well. And we've been pretty successful with that so far. Tomorrow morning, our chairwoman will be on C-SPAN Live, Washington Insider, and the New Yorker is doing an interview with NIHB. Hopefully that will bring lots of attention to our needs as well. Please, next slide. I'll move through these quickly. In phase one, there was nothing for the Indian Health Service in phase one. $40 million we were able to secure, and NIHB worked really hard on this through the COVID package, that money that came right out of the Centers for Disease Control and Prevention. The Centers for Disease Control and Prevention added another $40 million, making the package $80 million. But CDC is not highly proficient at working with tribes. And that's something we're working on, and it will improve over time. But in such a critical moment, we immediately wrote to the Secretary of HHS on behalf of tribes, informed by the kind of finger on the pulse work that we're doing. And we told the Secretary that the tribes want that money to go through the Indian Health Service, because the Indian Health Service has annual funding agreements with tribes who are self-governance. They have direct ways to fund and support direct service tribes and the urban Indian organizations as well. We did not prevail in that process, largely because there was no, many of you know that even though Health and Human Services is funded generally through the labor HHS approach process, Indian Health is funded through the Department of Interior appropriations process. So there was no way to transfer money because the construct of how this went up did not have an interior title. Very frustrating, but we're working with CDC to try to get this right. Please, next slide. We had $30 million that went to 9 regional tribal organizations and tribes over 40 million people. $40 million in non-competitive grants went to Title I and Title V tribes. Those are titles of the Indian Self-Determination Act. $2 million went to the National Indian Health Board for communications, something we were thrilled about but didn't ask for. $8 million went to the National Council of Urban Indian Health to share among their 41 organizations. Next slide, please. In phase two, we asked for $64 million. Well, we asked for a lot more, but we got $64 million to the Indian Health Service. And IHS secured an additional $70 million from the Public Health Emergency Fund. So in in phase two, IHS pulled in $134 million. And this was for testing equipment, personal protective equipment. And again, we held all tribes calls to talk about how tribes wanted this money distributed, how they wanted to use it and so forth, and inform the agency about that. Next slide, please. Phase 3, which was quite successful, we worked collaboratively. We have worked collaboratively with NCAI and NAFOA and other Native organizations, United South and Eastern Tribes Incorporated, the Alaska Native Health Board, also one of our member organizations, to ensure that what we were pursuing reflected tribal need. We did not get everything we wanted, but we did get $1.032 billion to the Indian Health Service. And I think that's a major victory. My chairman, Aaron Payman, always says, you know, we're 20% of the we're 20% of the population of America. So 20% of the whole $8 billion package, the whole package would have been $20 billion out of $2 trillion. So as Kevin said, we're going for that in phase 4. And you can read here what's included there. Next slide, please. So we just discussed this. We also brought in $125 million in a tribal set aside through CDC, $15 million set aside through the Substance Abuse and Mental Health Services Administration, specifically for tribes, and also for, I lost my train of thought for just a second.
15 million for HRSA.
Yeah, I got so excited, I got ahead of it. And the point is that this, again, is funding that we are working with the agencies to try to get it out the door in a non-competitive manner, in a way that gets that money to the tribes quickly, allows the tribes as much flexibility as possible to invest that money the way they know it needs to be invested for their communities. Next slide, please. We can skip this. I've covered this. Next slide, please. So phase 4, or as Kevin said, 3.5. One of the things that people don't think about on a day-to-day basis is that a lot of funding is brought into the Indian Health Service and into the tribal health system through third-party billing, Medicare, Medicaid, private insurance. Of the underfunded Indian health system that has funded at about $6 billion, more than $1 billion additional dollars are brought in every year from third-party billing. And those monies are invested directly back into the provision of healthcare for Native peoples. But when you have a crisis like this and regular meetings with your doctor are not happening, you're not bringing in third-party billing. You are not bringing in foundational funding that helps your tribal health system be stable and continue. When the government shut down and the Indian Health Service was not protected, it was third-party billing and the Special Diabetes Program for Indians that kept those systems operating. Now, as the businesses are closing for this crisis, their tribes are also losing their other economic methods to bring stabilizing money into Native health systems. We're also seeing rural hospitals in Oklahoma and Michigan furloughing 500, 600 employees, hospitals that the tribes depend on for healthcare. So this third phase, we need to make sure that there is a provision that answers the third-party billing question, the billions of dollars of lost revenue as we have answered it for mainstream America. We need to do fixes for Medicare and Medicaid. We need to ensure that certain line items of the Indian health system are brought into mandatory spending. And we need to permanently reauthorize the Special Diabetes Program for Indians. When you have a pandemic, that the number one vulnerability to acquire it or not survive it is diabetes. And we have diabetes that is off the charts in terms of by any measure in any other community in the country. It's time to just make this program permanent. It works, it saves money, and it saves lives. So there's more that we can share with you, but that's a good snapshot. Next slide, please. This is how to contact me. This is the website for the National Indian Health Board. I went very quickly, and I appreciate being part of this. Chemagwich, please support our efforts. Thank you.
Thanks so much, Stacy. I want to turn to President Newland from a tribal leader's perspective, about the legislation and about what you're seeing in your community. Thank you, President.
Sure, Miigwech Mary, Ani Buju, Nibana Mikana Bamose and Deshnakas, Mangandodem, Ganosha Kanangandonjaba, My name is Brian Newland. I'm the chairperson and president of Bay Mills Indian Community, way up here in northern Michigan. We still have snow on the ground and ice on the lakes. Mary and other listeners, this has been a really challenging time for us, like everybody. And, I'm a little scatterbrained today because we're trying to deal with the implementation of the CARES Act here in our community, and I'll touch upon that. I'm just going to walk through 5 things really quickly, and then maybe throw it back to the panel and wait for questions. But we started when preparing here at Bay Mills when coronavirus first hit the United States, and just putting some basic steps into place for what are we going to do if we have to shelter in place or close our government and work remotely. And even just that week or 2 head start to think about that proved to be really helpful to us. And we were able to transition our tribal government to remote work on the fly, scrounging up old laptops and having our IT department repurpose them, getting internet subscriptions and Zoom accounts and all that stuff. So we were able to transition to a remote workplace pretty quickly as soon as the threat became real here in Michigan, and that of course really helped us start then to focus on other things. We also tried to take a page the Lummi Nation's playbook. We don't have their health resources, but not to waste our time here sitting on our hands and just work under the assumption that at some point this year, we are going to see COVID cases in our community. And so to have a plan in place for when that happens and really try to dummy proof it to the extent that we can, and not have tribal council members, myself included, fighting over, what are we going to do when the virus already hits our community. And so, I really want to credit the Lummi Nation. I didn't reach out to anybody out there, but just the work you guys did, being publicized across Indian country, got us thinking about what we need to do here. And so we tried to borrow a page out of their playbook. So when Michigan started going to shelter in place orders, we did as well. The first part of the response set where we really encountered a lot of challenges in the bureaucracy was working with Indian Health Service. The process that the federal government was using was to push us into relying on state public health agencies for coordination for PPE and other public health needs, because we don't typically have a strong formal relationship with the state public health system here in Michigan. And then of course at the state level, they pushed us to our local county public health agency where we have, our fault, I guess, for not doing this sooner, but we don't really have a history of working with that department, really in close hand-in-hand relationship. So we've had to do that on the fly, and to have IHS and our trustee kind of push us in that direction, in this scenario was a big challenge, but we ended up being able to, get through it. So we put in a shelter in place order, and we backed it up with a curfew because here in Michigan, only essential businesses are allowed to remain open, and most of them are closed by 10 o'clock. And the curfew was not popular with a subset of folks in our community, but we made the decision that there is really no good reason to be out after 10 o'clock if there are no businesses open. And so unless you're going to an essential job or having a medical emergency, we wanted our folks to stay at home because we are a fairly densely populated reservation. We've also worked to build our testing capacity. As I said, we don't have COVID cases yet, but what we want to be able to do is to do widespread community-based testing where we can, as the country starts to pull out of this, and we want to avoid second and third waves of outbreak. And so we want to have the capacity to do really aggressive contact tracing and community scale testing. And so our staff has literally been ordering the component parts of test kits and trying to piece them together at our health center, so we have that capacity. We have also not limited ourselves to looking at the CDC and the state public health guidance. And our staff has really been looking to places like South Korea and Germany and Vietnam for guidance on what can we do to prevent spread, and really kind of got out of our normal rut of thinking that we have to look only at the federal government for guidance and leadership. Through our tribal college, we have also begun to manufacture personal protective equipment. We have 3D printers and some skilled manufacturing training programs with plastics manufacturing material or equipment. And so we partnered with our tribal college and a local university and actually local school districts and their robotics teams. And we're churning out about 150 face shields per day. We can't meet the demand for that, and our local hospitals and law enforcement agencies have been coming to us for that, and we're just supplying those at cost. And so that's really been our on-the-ground response. Of course, like almost all other tribes, we've closed our casino. We're not a big gaming tribe. We have 400 employees in our casinos on the reservation, and we have committed to paying our employees through the end of this pay period, which it ends on Saturday, and covering our employees' health insurance through the end of the month. To continue on beyond that is really going to stretch our ability to not only continue to pay that, but then have a functioning government. And actually today, we apply through the Small Business Loan CARES Act funding, and we were really frustrated that SBA issued that guidance that said tribal casinos are not eligible for those loans. We tried to repurpose or rearrange our employment or payroll on the fly to separate out our non-casino employees from the casino employees, and SBA has, for all intents and purposes, abandoned us. They haven't responded to phone calls or emails. Our bank that we work with has resorted to sending all caps, multiple exclamation point emails to SBA officials, to try to get their attention. And for those of you who are watching, that's not behavior that's typical of bankers, but that tells you really how, despite the best efforts of the chairman and Kevin and Stacy and other folks who worked Capitol Hill really hard, on the ground in Indian country, SBA is not meeting our needs. And right before this program, we were starting the paperwork and the public statements about placing 400 employees on unpaid leave because we could not get that loan through SBA. IHS, our work has gotten better with them. As I said, we had some frustrations. They were channeling us to state agencies, but we work really well with the Bemidji area office at IHS, and their staff there seems to go above and beyond, and that's been great. And the BIA has been pretty good to work with. We have a pretty good relationship with them, and I know that's not the same in other states. I imagine where you are, Geraldine, having IHS say, go work with the state of South Dakota and your local health agencies, would really, make you feel uncomfortable, to say the least, I'm sure. But on the CARES Act, I agree, Kevin, with you, Kevin, that tribes need to have the utmost flexibility in how we're going to use the coronavirus relief fund. I was pretty disappointed in the consultation last week to hear from the Treasury Department representative, speak almost as though tribes were some business that need to be strictly regulated. And many of us tried to make the point that if we can't use that relief fund to account for the missing revenues, we won't have anybody working in our government to incur extra expenses for a response. And, you know, it seems, at least initially, that there was a view on the part of some folks that those funds should be limited to, you know, buying extra swab sticks and pencils and things like that. And really, we should have the flexibility to spend that money to keep our governments intact. One example of that in our response, we have a Boys and Girls Club here in our community, and with the schools closed and people sheltering in place, you know, they can't do programming in person. So we've repurposed our Boys and Girls Club to be a Meals on Wheels program for 350 students in and around the reservation, and another 150 elders in and around our reservation. So they are out, they're making meals every day and out delivering them in our community, and expense that wasn't budgeted for. And if we run out of funds and we can't have the flexibility under the CARES Act to continue to pay them to do that, we're going to have a lot of folks in our community who are going without meals. And if you can't feed yourself on a daily basis, you're not going to shelter in place. You're going to go get food and worry about, you know, you're going to take that, meet that need, and worry about the risk of catching coronavirus later. Lastly, one area where we were caught off guard was, you know, we were so focused on our casino and our schools and our health center as potential vectors for transmitting this virus. But we have several prisons here in the Michigan prison system where a lot of our tribal members work as corrections officers. And the first case that we had in our county was actually an inmate at that prison. And it just so happened that the guards or the officers who were staffed to that inmate, 7 of them over the span of a week happened to either be tribal members or residents of our reservation. And the State Department of Corrections did not inform us of the exposure until 10 days later. We had a lot of those officers self-report, and they asked to be that their names be kept confidential because they were afraid they would get in trouble. You know, thankfully, our governor here in Michigan, Governor Whitmer, and her team and her tribal liaison, Winona Single, who's a member of the Little Traverse Bay Bands of Odawa Indians, and was on the faculty at Michigan State Law School, you know, pulled together many different departments and said, okay, you know, our prisons are not islands, and the folks who come in and work in the prisons go home to their communities. And we put a process in place. That's something that I encourage everybody who's watching and listening to think about, though, is that's another vector for this disease to reach your community. And lastly, on that point too, and I know she's watching this, but Judge Maldonado from the Little Traverse Bay Band shared with me something they were doing that we took as well, which was before any of this really hit Michigan, we filed a motion in our tribal court to release all of our tribal court inmates from jail and have them either have their sentences suspended or have them placed on house arrest. And our law enforcement has been directed to only transport people immediate threat to public safety. And everyone else were just citing and holding their cases in abeyance until this is over. Because once, you know, even the best run prisons and jails, you know, that's a petri dish, and once the disease gets there, it's going to spread very rapidly, and we just didn't feel that it was worth the risk of exposing our tribal members to COVID-19 while they were in jail. So that's my update. I'm happy to participate. I appreciate the opportunity. Miigwech, and I'll stick around for questions.
Thank you, President Newland. That was very helpful to talk about what's going on the ground, both from a health perspective and an economic perspective, and bringing up the issues with the tribal justice system and prisoners. I know Attorney General McPaul is going to speak about that later too. Now we'll kind of segue and talk about what's going on the ground with respect to the health issues surrounding COVID-19. I know we've been seeing on the news all the hot spots with New York, and Louisiana and Michigan, where you are, President Newland, in Detroit. And I know just in the last couple of days, I live in the Chicago area. There's a lot of reports that African Americans are significantly more likely to die from COVID-19. Like for instance, in the Chicago area, they make up only 30% of the population, but they're about 60% of the deaths. And unfortunately, I fear that we're on a later wave and could be in the same situation. So I'm going to turn first to Geraldine Church, who's in the Great Plains, because with the exception of, I think, one tribe in the Great Plains, all the facilities are operated by IHS. And actually, in the Great Plains, there's two of the governors who have not issued stay-at-home orders, I know, in North and South Dakota. So Geraldine? Geraldine? We see your slides. You might be on mute.
Hi, this is Geraldine.
Okay,
I'm so sorry. Yes.
Okay.
Thank you so much. I appreciate the opportunity to be with you all. I appreciate the folks that are attending the webinar and the esteemed panelists that I share this platform with. And I thank you for the opportunity to shed some light on some of the challenges that we are experiencing in the Great Plains. Just to start, the Great Plains Tribal Chairman's Health Board is a tribal organization that was formed by the 18 tribal communities in North Dakota, South Dakota, Nebraska, and Iowa. We house also the Great Plains Tribal Epidemiology Center. We oversee a number of local and regional grant programs that serve our tribes. And then most recently, we assumed management of the Rapid City Indian Health Service Clinic, which is now the Oyate Health Center in Rapid City. You know, one of the things that we're really reminiscing on is the fact that for the last 2 decades, Indian Health Service has really focused on diminishing hospital services. And the majority of, as you said, Mary, the majority of our facilities in the Great Plains is still federally managed. So we're quite concerned about the lack of capacity that our tribes, hospitals on the Great Plains have to address this outbreak. Also, as you said, we have a disproportionate rate of chronic disease that puts our population especially at risk. We're concerned about the long-term impacts. We do have some tribes in the region that are also whose sustenance relies on gaming and who are dependent on revenue from their hospitality industry to serve the needs of their communities. So understand that, you know, most tribes don't have a taxation system. So they really rely on the revenue from gaming to maintain their roads, to subsidize the woefully underfunded health system and a number of other services that they provide to their communities. So there's a grave concern that some of these health systems that are already underfunded and may rely on gaming revenue are going to be even more impacted by the fact that we're not providing as much primary care services in order to prepare for an outbreak in our communities. You know, there's an informal economy too on the reservation. So many of you may know that there's an already extraordinarily high unemployment rate. So there's cottage industries throughout our reservations that makes up the economic activity on the reservations. you know, as a tribal organization here in Rapid City, we're used to the many artisans showing up on Friday, payday, to share their wares and to, you know, to sell their goods. And you know, most recently we shut our doors to the public to keep our staff safe, and that was, you know, that was difficult because we know that in our community there are folks that really depend on anything from the community members that are known for their baked goods or their artwork, babysitting. A lot of those cottage industries are already interrupted. We're worried about their ability to, we're very remote, we're very rural. So we're worried about our tribe's ability to continue to access phone service and internet, which is already very, very limited. We know that we have to rely on these systems to support our tribes and lend technical assistance to their incident command teams. And it's not stable. We're noticing even in Rapid City, we had one of our major internet carriers go down for the day. We're noticing that our cell service is really, really spotty. So in areas where it's a little more rural, where that infrastructure is already limited, we're seeing that there's an impact even now, and we haven't even begun to experience. You know, we're just making our way up the curve. We're also concerned, like Brian mentioned, about the impact and the pressure on our law enforcement programs. Unfortunately, in the state of South Dakota, we do have a large number of our communities that are represented in some of the prison systems here, and we're aware that there is already spread within the South Dakota Women's Prison. We wrote some letters of advocacy to the governor, asking that they take some of the same measures that Brian was talking about in their community. And then as an organization, you know, we're a health organization. Our primary role is to provide technical assistance and support to our tribes. And at the same time, we are wanting to keep our staff safe. We want to make sure that they have the ability to work from home if they can. In 2 weeks' time, we stood up a third clinic just for the folks that are showing up with respiratory distress. In addition, we had to move about half of our workforce on the public health side of our operations to work from home. It was incredibly daunting. We were fortunate that we have a student workforce health professions opportunity grant, and we had a number of laptops already on hand that we could send our staff home with to work from home. But our IT, you know, when he went to look for laptops to send our staff home to work, you can't get some of the typical things that you would order from Best Buy. Just like our toilet paper, a lot of the technology equipment and laptops are on back order. We're very concerned because of the remoteness of our tribes, of the level of technical assistance that they may need in order to stand up their own emergency management infrastructure. We're concerned about their access to PPE and testing supplies, additional beds and staff. In some of our communities, we've been able to identify additional space, but our worry is having the staff, having the additional doctors, nurses, respiratory therapists, even if we're able to create temporary hospitals, we're very concerned about the lack of staff. And we've been talking to the state of South Dakota, and they're pretty much in the same position that our tribes are. Our reservation emergency rooms may be in a position where they have to treat local non-Indian patients that typically might not go to Indian Health Service, but because we're the closest, their hospitals might be the closest to where some of our non-native neighbors are. We are not only looking at the overflow or the increase in patient care for our own members, but there may be other community members that will need care. Our epicenter they've just been phenomenal. They have just from the get-go have started to develop policies that helping with codes for the tribes, helping with policies for tribal health organizations to put policies in place related to COVID, isolation and quarantine, shelter in place. There's just a whole lot that we are not only thinking about in terms of our work here in Rapid City, but to help the 18 tribes that we provide support to. So again, appreciate the opportunity to share what's happening here. North Dakota is a hot spot right now, up in 3 affiliated, several cases there. We were on the phone with the chairman up there this morning, and then Oglala Sioux Tribe had their first case last night. Our chairmen have been taking this very, very seriously. I think probably more seriously than even our governors have, because they know that once this takes off in any one of our communities, that the results are going to be devastating.
Thanks so much, Geraldine, for all you're doing. Now I want to turn to Dr. Grimm. Geraldine kind of talked about what's going on with facilities where IHS is running them. Dr. Grimm runs the Chickasaw Health System, which is run by the tribe. So Dr. Grimm.
Good afternoon, everyone. It's an honor for me to get to be a part of this panel. I appreciate the American Bar Association for putting this on today, and was very excited to see how many people signed on today to hear what's going on in Indian country. I just wanted to show you where I'm speaking to you from, because I know there are people on from all over the country. Chickasaw Nation Reservation is located in south central Oklahoma. The colored counties that you see are the legislative districts that we have, and we represent over 66,000 citizens, and our jurisdictional area spans 7,648 square miles there in south central Oklahoma. And I'm now having trouble getting mine to go down. They need Allie to
Oh, Allie, might you be able to do Dr. Grimm's slides?
Let me try it again here. I'll try to share a different one and start it back up again. There we go. I wanted to just quickly show you the the medical center and the 3 facilities we have. We have a 72-bed hospital in Ada, Oklahoma. We have an outpatient facility in Ardmore, Oklahoma.
Can you share your screen?
Is my screen not sharing right now?
No.
No. Well, we did this all good at the beginning here. Let's see here. How's that?
Yep. Got it up
All right. Again. Well, you missed the first few facilities. We're going to just keep going out of the interest of time.
Yes.
This is our clinic in Tishomingo, Oklahoma. And this is the one that doesn't want to go. Try it again. There we go. Our clinic in Purcell, Oklahoma, and those are spread out really across our jurisdictional area so that they're within 30 minutes or so of our entire population. We are a fairly large health system for Indian Health Service. We have 90,000 active charts, over 700,000 patient visits annually. And as soon as we heard that COVID virus had hit the coasts, we immediately took action. We started doing the research that was necessary. We implemented an incident command system and started screening at our front doors. Any patients or visitors that were coming in with them, we had our employees entering from back of house location. We began screening them each day, and we put in stricter facility visitation. We're down now to really no visitors in the hospital, with the exception of OB. We do about 1,000 births a year. We're allowing one person into the facility for certain visits with the mom, and then also during the birth. We have set up things so that externally a patient can get on Zoom with their family. If they don't have that capability, we've set things up for them because we've heard in the coasts where things are getting really bad that, you know, we have patients that are passing away with family unable to be present. So we wanted to try to take care of that. We have canceled all of our routine appointments for most of our outpatient services. We're communicating with our patients with many of our patients signed up for text notices, and so we've been sending out notices to them with that. We've set up 3 different call centers too, one for employees, one for patients, and then we have a testing results call center I'll talk about a little later. If there's been any bright spot in this for the health industry, it has been that we have rapidly changed to telehealth and virtual visits. We had that in our urgent care prior to this, but now all of our clinics, family practice, pediatrics, urgent care, even our specialty clinics are doing as much as they can through virtual visits. We have about 1,500 employees in our system, and we know that this is not going to be over with quickly. And so we had all hands on deck initially. We had to essentially turn our system upside down in the way it operates. And as we shut down some of those outpatient sorts of services, we've put together a labor pool for emergency needs, and we're repurposing staff, retraining them for what might be coming, as well as for things that we're doing right now, like testing centers. We did that you know, to start reducing the use of personal protective equipment because some of our services like dental use a lot of personal protective equipment, both sometimes on a day-to-day routine treatment, but especially when they're doing surgical procedures as well. Any of those services that we have put on hold for now, they are seeing emergencies. So if anyone's in pain or has emergencies, we are still seeing them. We just this week, after we felt like we got everything prepared, we started implementing a rotation schedule with our staff. So we've essentially broken up all of our departments such that we'll have 1 week on and 1 week off. We're doing that to conserve PPE, but also we had an incident as we were all hands on deck trying to get prepared where one of our team leaders that would have huddles with staff throughout the day ended up with COVID, and then we potentially could have taken out an entire staff. So we quickly converted to this schedule for both of those reasons, so that if some of our staff get sick and it happens to spread, we'll still have staff that we can rely on. Also, like many places, started to set up COVID testing centers. The picture you see right there is our medical center campus, and those white tents at the bottom of the picture there are 4 testing tents that can allow drive-through on both sides of them so that we can have essentially 8 tests being given at one time, and we can push through 500 tests per day in that setting. However, much like most of the country, we've had difficulty getting a hold of the testing media. We've now put those testing centers at 3 of our 4 facilities. We're testing our patient population, our employees and their family members if one of them happened to test positive, and then we're considering opening to the general public if we can get enough testing supplies. Governor Bill Anatubby, the governor of the Chickasaw Nation, declared a public health emergency early on, and one of the things that does under the Indian Healthcare Improvement Act is gives us the ability to see the general population, non-beneficiary population, if it'll help protect the public health of our Indian people. We have also taken care of all the legal issues. I know this group will be glad to hear. We've developed a playbook that will essentially allow us to replicate these centers. We have all the necessary information, paperwork. What you're seeing there on that top form is a form that we developed that has little stickies and all those little spots for photo IDs, insurance card, etc. The patient drives through. They have a place they can park, go fill out this form, place their various IDs there. They drive to the next station. We take a picture of it with a phone and we cast that to a Bluetooth printer. And then when they pull up to the testing center, we verify it's the same person. We do the test, and we also have all the information we need to bill for those right on that form too. And we never have to take the paper back from the individual, so there's no risk of transmission that way. One of the things that happens in mass screenings like this too is you're looking for positives, and so very often anyone that's negative may be waiting for a long time to hear about their test results. So we implemented a test result call center where a patient can call us, or as we get results each day, we make many outbound calls to patients to give them negative results. If it's a positive result, that goes to their primary care provider, and that person then contacts the patient, and they discuss what the patient needs to do from that point forward. Just a last little slide about the limitations in rural healthcare in rural America, Indian country. Our centers are primary care centers for all sorts of the delivery of healthcare. Pharmacies, x-rays, physical therapy, you heard me mention optometry, dental, hospitals if you have a hospital, you know, women's health, and you name it, almost anything you would seek in the private sector you can get. And so as we're preparing for these emergencies, it's putting a lot of other general care on hold. Early on and we still have trouble getting access to testing media. The Indian Health Service was just recently given some of those Abbott tests that do tests in 5 minutes. We're going to be getting some of those in that allotment hopefully by the end of this week, so we'll be able to do some spot immediate testing. You've heard about the PPE issue, and the other issue with rural population is communicating to them a lot about what's going on. And then our state was a little late in making some declarations, and we had and still have a safer in place order, not a shelter in place order. And there's a little difference in that. I'm assuming, since most of the audience is attorneys, that you would know that it's not quite as strong as you know, a shelter in place would be. So I will stop right there, Mary, and thank everyone for being there, and I'll be around if there are any questions.
All right, yes, we have about half an hour more and we still have 3 speakers, so I want to try to get to everyone. I'm going to turn next to Virginia Heydrich, because we haven't talked about urban Indian populations. As we know, I think 2/3 to 75% of Native Americans live in urban communities. And Virginia, you're out in California where the governor acted early. So want to hear your perspective on all of this.
Yeah, Ayukui, Nakna, Virginia, Hedrick, Shregon, Mewamecha. Good afternoon. My name is Virginia. I'm a member of the Yurok tribe and the executive director of California Consortium for Urban Indian Health. We do policy, advocacy, and public health programming for 10 urban Indian organizations in California, which include 2 residential treatment facilities. So it's important we talk about urban Indian organizations and communities. Sort of the majority of what we're talking about includes a wide range of services. It is true that urban Indian organizations are in some of the very first hotspots in the nation. Specifically here in California, we have an Indian health program in Santa Clara County, and Santa Clara County has to date had the highest number of deaths, and the first cases originated in Santa Clara County. So the response in that county has been really intense. Drive-through testing occurred in that urban Indian organization within just a few weeks of the pandemic. It is true we are fortunate to be in California in that our governor has been acting very swiftly to issue shelter in place. We have school closures for the rest of the school year through 2020. We should be returning in the fall. And then in terms of incarcerated relatives, the state of California has issued guidance on not detaining any low-level offenders and releasing those who might be eligible for an early release. So also really great public health practices happening there. We're a Public Law 280 state, so in terms of what's happening on tribal lands, it's really interesting to watch California tribes as they enact their emergency declarations and potentially closing their borders. What is happening between tribes and county officials is really interesting. I think in any emergent situation, we see vulnerable populations become more vulnerable. So I saw questions in the chat talking about domestic violence, sexually exploited children and women. We're all really watching this closely to see what happens with MMIW, how cases are reported or not reported. Very difficult to track these things during a shelter in place. In homes where there has already a food insecurity, school closures deeply impact those families. So, you know, here in California, many schools are offering free lunch, although there are not adequate bus systems in urban areas to ensure that urban Indian kids have access to those schools where lunches are being provided. So there continues to be a number of barriers. If I could hit any high levels, if there's any silver lining to see in this, it is that what people in public health policy have been asking for so long, we're seeing some changes in terms of access to telehealth. So telehealth in California has been broadened in that providers can access patients however they can access them. So if a patient is accessing their provider via text, phone, Zoom, even Facebook has been a place that has been pushing the boundaries of how we access patients and ensuring that folks have access to their healthcare providers. So really getting into the 21st century. In terms of accessing food stamps, the Supplemental Nutrition Assistance Program in California, we have had long barriers in accessing food stamps, and that individuals have to go through a face-to-face interview process to be approved for food stamps, and that face-to-face interview process has been waived during the pandemic. So some barriers are being eliminated in areas that I think are really critical for patients. That's just a couple of highlights. If I could mention any wins. You know, the Indian Health Service has here in California, our area office, done an incredible job in getting resources out to Indian health programs, specifically urban Indian organizations, as quickly as it's coming. To that the Indian healthcare delivery system is reliant on third-party billing, particularly our Medi-Cal and Medicaid eligible patients, and individuals' access to dental care has greatly reduced in California in the shelter in place, in that there can be no drilling for dental care, and only emergency dental care is accessible. And so I think we'll start to see the long-term impacts of that shortly too. As we know, dental care is incredibly important and has significant impacts to mental health, as all of this is impacting mental health. So there's so many great questions in the chat, and I think we could have entire webinars on any one of these topics, right? So just appreciate the panelists who have addressed so much already.
Thank you so much, Virginia, for bringing the urban Indian perspective, which is very important. Next, I want to turn to Elizabeth. We've heard from Lummi about some of the things they're doing. I know we all see maybe on TV, they're setting up alternate care sites in the Javits Center in New York. I know here in Chicago, we have McCormick Place, and I think Elizabeth's going to talk about some of the things they've been doing on Lummi. So Elizabeth.
Thank you, Mary. My name is Elizabeth Coronado. I'm a tribal member of the Picayune Rancheria of the Chukchansi Indians, which is in California. I'm a staff attorney with the Lummi Nation, and I'm going to talk about Lummi Nation's alternate care site planning that I have been involved with the health team. Just to note, Dr. Dakota Lane was initially going to give this presentation, but given the COVID-19 pandemic happening right now, he's quite busy. So they volunteered me. So here is just a picture of our alternate care site on the top of my presentation. So I just wanted to start with a quote from our chairman, Lawrence Solomon, during community update. The quote states, "Today we are in the same position as our ancestors with the Great Flood, when the Great Flood arrived. Like our ancestors, we're doing everything possible to ensure that our children have everything they need in their canoes to survive. We want to make it clear that our children need the teachings from their elders. We refuse to give up any of our elders during this flood." I feel like this quote really highlighted the severity of COVID-19 and its impact on the Lummi community. So what is an alternate care site? So many jurisdictions throughout the United States have alternate care site planning within their public health emergencies. And so it's a location that is not currently providing healthcare services that is converted to enable the provision of healthcare services to support patient care required after declared catastrophic emergency. So some examples here in Washington State and King County, they converted the CenturyLink football into an alternate care site. In Shoreline, they developed assessment and recovery center, which is kind of a hybrid of both medical sheltering, but then also providing care in that site as well. For here, the Lummi Nation, the health team converted the fitness center into our alternate care site. So many alternate care sites examples, our jurisdictions usually utilize football fields, community buildings, schools, gyms. So here the Lummi Nation closed the fitness center pretty early on because of the pandemic. And so they were able to convert that into the site. Just some background on why the Lummi Nation health team recommended this. Here in Whatcom County, there are about 1.1 beds per 1,000 population. And in contrast, Italy has 3.18 beds per 1,000 population, which is a pretty significant difference. Italy has been very impacted in terms of needing additional beds. So our alternate care site will be a 20-bed inpatient unit. So some early on barriers the Lummi Nation has dealt with in preparing for this alternate care site. First was properly defining the facility. So about 3 weeks ago, the health team presented this idea of this hospital overflow unit to me. And so I had to do some significant research on how are we going to classify this site. And that's when I found that other jurisdictions utilize alternate care site terminology to be able to be reimbursed. So we're kind of moving away from this idea that it's a hospital, because ideally we're not going to meet these conditions of participation that many of these hospitals are classified as, that you're able to bill third parties like Medicare. There's just no way for a temporary facility that you could even meet those conditions. Another big issue that we faced was access to IV medications and supplies. And that was something absolutely need to operate. So McKesson had very low quantities to be able to order. We requested it from the Indian Health Service, which was to no available. We reached out to our local hospital, which is Peace Health St. Joseph's, and they indicated that they also will need all the IV medications that they currently have, and that they're unable to release patients with those needed medications to our site. And then we also did reach out to the Washington State Emergency Management Division, and that is in process. Hopefully we'll get some medications from them. So we'll see. So some impacts. So right now, one of the biggest issue was figuring out funding for this site. At first, we approached IHS and CMS, which was not helpful, essentially. CMS, many states are getting waivers, Section 1135 waivers, to be able to operate some of these sites. But it did not fit to what we needed. We don't currently operate any inpatient facility. We don't have any license for that or any certification, either through IHS, CMS, or the state. And they didn't provide a clear path of, we're going to waive these conditions of participation so you will be able to get this certification to be able to bill Medicare and Medicaid. And because that's not a certified facility, they're not going to reimburse us for the care that's provided in that site. So then we approached FEMA. And here we're located in Region 10 of FEMA, and it seems across the board this is very new. They don't exactly know how reimbursement is going to look like for these healthcare sites. For example, FEMA doesn't provide reimbursements for current permanent healthcare providers. So our doctors who will be providing care in this site, that's potentially not a coverable expense under FEMA because there are current employees. Although our income will be significantly impacted because we won't have access to those third-party reimbursements that we usually supplement to cover these salaried employees. Additionally, I mentioned there has been no support from the Indian Health Service. We've had multiple conversations with them. They've indicated some issues of us even being able to operate under our funding agreement. And importantly, in the Portland area, which is the region that we're located in, there's not a single IHS-funded hospital for American Indians and Alaska Natives. So that means that if the 253 hospital beds here in Whatcom County are full, the Lummi community has no other option for inpatient care. So this was a solution to that. We'll create the site to free up those hospital beds for the most acute patients. Some legal impacts, as I mentioned previously, Indian Health Service indicated that there are some limitations within our self-governance compact, which could impact Federal Tort Claims Act coverage. Many of you probably know that FTCA coverage is tied to our compacts. And if they make a determination that this isn't covered in that, then that opens up potential tort liability. Also, there's no federal uniform liability protections that apply during declared emergencies. So some states and local jurisdictions may adopt some protections for tort liability, but that's not uniformly applied across the United States. Additionally, defining crisis standards of care has been a huge legal issue for us in defining what that means to the Lummi Nation. And for those that aren't really aware what crisis standards of care are, a definition by National Academy of Medicine, it's optimal level of care that can be delivered during a catastrophic event requiring substantial change in usual healthcare operations. So we're under this presumption that we are in crisis right now. So the standards of care may change because of that. That means we have limited resources, limited staff, we're not providing care in a usual licensed hospital that meets these conditions of participation. And so that care changes. We're not providing the most patient-focused care at this moment across the board, across the United States and across the world as well. And then another huge issue, which I have found, is the lack of public health emergency planning by the Indian Health Service. And that public health emergency planning needs to include support for tribal self-governance tribes that are working on alternate care site planning and defining these crisis standards of care. The federal government has both a treaty and trust obligation to provide both care and support to self-governance tribes. So it's absolutely not acceptable that Indian Health Service are bringing up all these issues of why we can't do this. It's not a matter of whether we can and can't do it. So we have to do this. Otherwise, the Lummi community may not have access to inpatient hospital beds. So I've kind of gone over this very quickly because I want to give time to other panelists to talk about other issues. Oh, I did want to touch on one last bit. So in order to pay for this alternate care site, the Lummi Nation has been utilizing funding that was set aside to build a new health center. And so if we're not able to get reimbursed through FEMA or HHS, then that could impact, future construction for this healthcare facility. As when speaking with FEMA and participating in IHS calls, there doesn't seem to be a clear plan between FEMA and HHS on who's going to cover what expenses and how that's going to be covered. It seems like there's money there, but there's not exactly a clear plan, and everything changes day by day here. Anyway, I just wanted to say thank you for listening in on the conversation. I can be contacted by email if you have any questions about Lummi Nation's alternate care site planning. We are not operating right now. We're waiting for whenever there's a hospital surge, and then we'll be fully operational. Thank you.
Thanks so much, Elizabeth. That was really helpful, and it actually flags for, I think, all of us, maybe some of the things that need to be in the 4.0 or 3.5 bill, some of these legal fixes. So I hope Stacy and Kevin and others are taking notes on that. And then last but not least, I want to turn to Doreen. She's the Attorney General of the Navajo Nation, which is the largest tribe in terms of land mass, and I think they have about 400,000 members. And if we talk about New York as a hotspot, I think right now, at least in terms of the statistics that we have that are most certainly incomplete, Navajo Nation is definitely a hotspot. I think as of April 6th, you had, I think, over 380 cases on the Navajo Nation, which, by the way, spans several states. So Doreen, turn to you. Doreen, you may be on mute. Doreen, we can see your screen, but we can't hear you.
Okay, how do I go back to my screen?
We can hear you now.
Can you see my screen now?
Yes, we can.
Okay, great. Thank you, Mary. As Mary said, my name is Doreen McPaul. I'm the Navajo Nation Attorney General. I oversee the nation's Department of Justice, as well as our Office of the Prosecutor. And we've been actively involved in working with the Navajo Nation with its COVID-19 efforts, and from the perspective of in-house lawyers that are advising our clients. And this first screen, I just want to point out that one of the first things the Navajo Nation did for our members is to translate what COVID-19 means into something that is meaningful. And so the Navajo translation is there, or the Navajo translation is there, and it means roughly massive cough. And I asked my six-year-old how to say that, and he taught me, and I'll tell you later if you really want to know. This first slide I want to just share is a map from our Navajo Nation Epidemiology Center, and it outlines, as Mary said, that the nation covers 3 states within the Four Corners area, and within those states we cover 11 counties. And so this creates some challenges for the nation in terms of coordination across jurisdictions, and not just related to public health. I mean, this goes to school closures, this goes to road closures, and jurisdiction over those roads, as well as voting issues, et cetera. I want to point out that the red area in that map is Navajo County in Arizona. That is where we had our first confirmed COVID-19 cases. And from there, there's been wide rapid community spread. West of there is Coconino County, which is the 2nd largest county in the United States. And just west of that is the Grand Canyon National Park, which closed just a week ago, and was problematic that that park remained open for so long. The other part of the screen is the IHS data as of 2 days ago regarding service area information, and you can see that the Navajo Area Indian Office has been very busy. There are 330 pending test results, as well as some underreporting, but part of that is because you'll see from this slide that in addition to our Indian Health Service partners, we also have 5 638 hospitals that aren't run by the tribe, but authorized by the nation to operate on tribal land. And so this also presents a unique challenge of data collection and getting information from, we rely on IHS and 638 to provide that information to the nation, not just related to COVID-19, but related to resources and needs so that we can advocate for that at the national level. One of the things I want to point out with respect to this map is you'll see the legend there points out all the different kinds of roads. And I just pulled this from the IHS website. I mentioned jurisdictional challenges, and the ability of other tribes to close their borders is something that we kind of envy right now, because you can see from this map that it is impractical for the nation to do that on any effective level. I also want to point out from this map that pink area in the middle is the Hopi Nation, Hopi tribe, and so all of the decisions that the Navajo Nation is making with respect to COVID-19 for our jurisdiction areas have an impact on the Hopi Nation, and so that we are coordinating some of our efforts with Hopi because of that impact. This slide shows the Navajo Nation, which covers over 27,000 square miles. It's comparable in size to West Virginia. I saw this map or this image being shared on social media, and the data was a little bit inaccurate, so I updated it as of the April 6th to show the actual population on reservation as opposed to total enrollment. And you can see the disparate impact of the nation when you compare population and the COVID-19 impact. You can also see from this map how completely surrounded Hopi is by the Navajo Nation, so coordination is important. And I also put a note there that San Juan Southern Paiute is also a federally recognized tribe. Their members live on the Navajo Nation. They don't have their own recognized land base, and so they're not exercising jurisdiction at this moment. This is what the nation's curve looks like. As Mary said, as of April 6th, we had 384 cases. That number is up to 426 as of yesterday, including 17 deaths. The nation's efforts to flatten the curve include a health command center that is operated under our Navajo Department of Health. All of our executive branch employees have completed mandatory FEMA incident command training and are tasked to that health command center to help support the efforts of our public health experts. As Chairman Newland mentioned earlier, prior to any cases on the Navajo Nation, our government declared an emergency. Our schools were closed. Those are closed through the end of the year. Our government offices were closed, and our enterprises are closed. And once we had our first confirmed case in that red map area that I showed earlier, on March 17th, our public health experts in our health command center had started issuing public health emergency orders, and we have 5 currently that do everything from limit gatherings to close the nation to visitors. We have a curfew, and we have a shelter-in-place order as of March 20th, and our shelter-in-place order preceded any of our surrounding states. New Mexico, Arizona, and Utah still does not have a statewide shelter-in-place order. But in addition to these efforts, we have regular leadership discussions, daily briefings with our public health experts, as well as increased coordination with FEMA and the National Guard. There's a lot of public education efforts that the Navajo Nation government is doing, and events to assist our vulnerable populations. With the Department of Justice, these are just some of the legal issues that our office sees. We have 2 attorneys in the office right now. It's just me and the Deputy Attorney General. The rest of our 33 attorneys are working remotely and keeping our government function, primarily related to these efforts. One that I want to point out in particular is that looking at this free exercise of religion issue under our Navajo Nation Bill of Rights is really important, because our initial cases and the rapid spread was traced to a revival in a very small community that was later closed. And so being able to advise our enforcement agencies that they're able to disperse revival and religious camp group activities was really important. And when we looked at this, it was We were careful to consider Navajo Nation fundamental law as well as our modern law, and we were also very careful to distinguish between Christian church gatherings and Navajo traditional ceremonies. But I won't go through all of those issues, but those are just a sampling. Additionally, there's legislation that we've worked on. The Navajo Nation Council has passed several emergency legislations. I think they have a special session that's upcoming to consider a price gouging law as well. With respect to enforcement, our Health Command Center has several avenues to enforce these standards. Our office primarily works with the Navajo Police Department through our prosecutor's office. We have 15 prosecutors on the nation, and the police department initially was doing checkpoints to provide education to the public related to COVID-19, but they have started issuing criminal citations, and our prosecutor's office is handling that. This is what our justice system currently looks like. Our courts are closed to the public, and they're trying to operate just by electronic means that create some challenges in terms of technology and infrastructure across the nation. With respect to our jails, our inmates are being released on a case-by-case basis, and there's a lot of coordination between our prosecutor's office, our public defender's office, and our courts to effectuate that. This is the emergency legislation I referenced earlier. With respect to health challenges, I think our problems are similar to most tribes across the country, but probably proportionately larger just based on our land base, size, and population. But our medical facilities are at or exceeding surge capacity now. We have staffing challenges at our hospitals. We are closing smaller clinics, or IHS is closing some of their smaller clinics to detail those staff to the hospitals to relieve the hospital staff. Like other places, we have insufficient medical supplies, test kits, equipment, and bed space. And the photo that you see here is a FEMA station that was established in my hometown community of Chinle in our community center. So I don't know what's next, but we will continue to do the best that we can to coordinate our efforts to educate our members, to protect them, as well as to advocate for the nation as a whole. For other tribal attorneys on the program today, I do want to share two important resources. One is Turtle Talk has a repository for tribal documents and resources, including court documents and ICWA-related documents, and the Tribal In-House Counsel Association also has a listserv, and so there are conversations that are happening across the country throughout that listserv, and so those resources are there. And that's it. There's my contact information and my new mask. Thank you.
Okay, I don't know if we've got Doreen back, but we're kind of at the hour anyway. Doreen, are you back, or she's on mute now? I see. Did you have some final things to say?
That was it. Thank you.
Oh, okay, great. Well, we're at the hour. Unfortunately, I think we ran out of time, but I think a lot of the questions were answered in the presentation. But I think one of the things that all the panelists have graciously done is they've all given their contact information. And I think we're gonna provide all the PowerPoints on the ABA website. We'll send that out. So you'll be able to have that. I'm sure all the panelists are fine to be contacted. We're going to try to answer the questions. I saw at one point there were about 22 questions were answered already, 50 were not, but we'll try to work through and provide some answers to those. So I want to thank all of our panelists and the congressman today. A spectacular panel. We hope you enjoyed it. Please consider making a donation to the section of Civil Rights and Social Justice at americanbar.org/donate CRSJ, so we can continue with these free rapid response programs. Thanks to all our co-sponsors, thanks to all the panelists, and we hope you join us at americanbar.org. You don't have to be a lawyer to be a member. / if you want to join the section of Civil Rights, which has a Native American Concerns Committee. And we will try to follow up with some of the answers and the PowerPoints. And also you will be getting an evaluation form Please fill that out. We love to hear your comments. And if you would like another panel on going a deeper dive on any of these issues or different issues, we're happy to do that. So thanks everyone for joining today. Thank you.